Friends, welcome to my hospital at Ranaghat, West Bengal, India. This is a white hard cataract. Let us observe the surgical steps. This is the main incision at a selected site with a 2.8 mm keratome. This is a side port on the right side of the main incision, about 3 clock hours away. And this is another side port on the left side of the main incision, about 2.5 clock hours away. Now, an air bubble is injected into the anterior chamber, and then trypan blue 0.06% dye is injected, and it is sprayed uniformly all over the anterior capsule. Now the dye is washed out. If you inject the dye underneath an air, the staining is immediate. Now, viscoelastic substance 2% hydroxypropyl methyl cellulose is injected into the anterior chamber, and it is sprayed over the corneal epithelium. It improves visibility as well as it protects the corneal epithelium. Now a 26 gauge bend needle is used to incise the anterior capsule, and in this case no fluid came out. We can see radial spokes, and there is lot of convexity of the anterior surface of the lens. So I have made a small rhexis first. I call it a mini rhexis. And now I am aspirating some cortical matter to reduce the intralenticular pressure, and then after aspirating this cortical matter, if I inject viscoelastic substance, there will be flattening of the anterior surface of the lens, and the chance of rhexis run out will be minimized. 2% hydroxypropyl methyl cellulose is injected again, and now a venous scissor is taken and a very small cut is made in this way, like this. Make a very small cut and take the ureter again, hold this tag, go anti-clockwise again, and this time make an adequate size rhexis. The control over the anterior capsule is 100% if you reduce the intralenticular pressure in this way, and you can make an adequate sized fairly round rhexis, and you don't need a femtolaser if you do rhexis in this way. And now you can see that the nucleus rotated without hydrodissection. So this is preintumescent cataract. Now is the time to introduce the tip of the phaco handpiece. This is a hard cataract, and I am trying my submarine chop. Go through the substance of the nucleus towards the opposite equator and chop it. In this case, the nucleus is quite brittle, and I hope it will divide into two halves. Let us see. Yes, the nucleus has been totally divided into two heminuclei. And now this is one chop, and this is another chop on this heminucleus. So this heminucleus has been divided into 3 parts, and now each part is brought at the center of the anterior chamber and emulsified. Attack from the apex is my habit or my practice. This is the other heminucleus. This appears smaller in size, and I am lifting off the inner edge and applying little bit of energy, and the heminucleus divides into two pieces. Each nuclear fragment is emulsified and removed. This is the last nuclear fragment. I remove the chopper so that leakage through the side port stops. Antechamber becomes more stable. If the piece gets stuck, just dislodge it and again remove the chopper. That's it. The nucleus and epinucleus has been managed. And now viscoelastic substance is injected, and now is the time to remove the cortical matter. Phaco power used in this case is 80%, flow rate is 45 ml per minute, and vacuum is 450 millimeter of mercury. This is the cortex subincisional cortical matter, and this is the cortex from 9 o'clock. So after cortical cleanup, the posterior capsule is polished as much as possible. You can do hydro polish, in which you use the irrigating jet of fluid to polish the posterior capsule, like this. And now in this case, a foldable intraocular lens is being implanted under irrigation. Dear colleagues, this is an unedited video, and you are watching each and every step of the surgery. The lens has been placed in the capsular bag, and the irrigating probe itself dials the lens. Most of the time, Sinskey hook is not required. And now this is a bit of moxifloxacin. The side ports are hydrated so that these wounds become waterproof. And now a final lavage of the anterior chamber is done. Irrigate the capsular bag behind the IOL to remove anything over there. The antechamber is formed nicely and the case is concluded. Thank you very much for watching. The aim of this video is to inspire you to improve your surgical skills and do very good service to the humanity. Thank you very much for watching.